Okay.
I think we are YouTube live now. हाँ जी।
Hi, good evening all.
Sir.
Hello, good evening, sir.
Hi.
So, sir, it is now 7. I think we can start, and we are YouTube live also.
Yeah.
So, Dr. Anand Nagar,
Yes, Dr. Ravi.
yeah, please.
So should I start first or you will start?
Yeah, please, आप बोलिए. I'll start.
You can start directly because yesterday we have done introduction.
Yeah. Okay. So, hello friends, very good evening again for this Jaipur surgical tutorial 5th master class. The theme is on surgical critical care. We had excellent 4 sessions yesterday, and we got immense response from the audience, also on YouTube. We had initial assessment and advanced assessment part yesterday. Now we will see that how we are going to manage in surgical ICUs. So the core concept, basically, these will be going to sensitizing topics to you people, because these are very lengthy topics in all. In a nutshell, I'll say. Let's see how it goes. I'll introduce our session chair, Dr. Nikhil Ajmera sir. Dr. Nikhil Ajmera sir is head of the department critical care medicine at Sant Durlabji Memorial Hospital in Jaipur, and sir is a prolific speaker himself. But we have handed over the responsibility of session chair this time. Sir is a very learned person, an avid learner himself, and a very good teacher also. So I wish I wish a very successful evening this day. Sir, please, I hand it over to you to introduce our speakers and the sessions further on.
Many thanks, Dr. Ravi and the team Jaipur Surgical Tutorial. I think it's a wonderful concept and we are doing great. Yesterday's sessions were also great, and now I hope and I wish all the participants and the speakers the best wishes for the successful completion of this tutorial. So, good evening all. Today's evening we are starting with the session by Dr. Pramod Sarva, and he is a consultant critical care medicine Eternal Heart Center and Research Institute, Jaipur, and he is practicing critical care medicine since more than 10 years. He is a passionate learner and excellent on-site physician, and his core area of interest are critical care ultrasound, ECMO, pain management, and intensive care quality improvement. And he's a part of institutional committee also for clinical and quality improvement in ESCC, and he has got many original publications and book chapters to his credit. The achievements in awards, he has got the Indian West Zone Conference of Anesthesia Gold Medal, and for Dr. Shobna Mehta, Memorial Gold Medal also. So the topic of Dr. Sarva is the management of sepsis, the surgical site infection, and skin and soft tissue infection in surgical ICU. So handed over to Dr. Pramod Sarva.
Thank you, Nikhil sir, for the kind introduction. Let me share my screen. Is it visible?
Yeah.
Okay. So good evening, everyone, and thank you, Nikhil sir. And I think I'm very glad to be part of this initiative. And thanks Dr. V.K. Kapoor, Dr. Ravi, and Dr. Anand for adding me in the part of this initiative. So my agenda over next 20 minutes is to explore about surgical site infection, how we can prevent it, how to identify sepsis, and how we can deal with sepsis. So, any infection in the surgical wound that occurs within the 30 days after the surgery. And mind you, if the implant is involved, the duration goes up to 1 year. It includes the skin, subcutaneous tissue, deep facial layers, and deep-seated organs, or you have purulent discharge or an organism is identified from the surgical site. It is surgical site infection. Depending on the site, it can be superficial incisional site, deep incisional SSI, or organ space SSI. So why uh, every surgical procedure certain carries certain risk of getting infected, and depending on the surgical procedures, we can divide into that surgery into the four part upon the risk of getting infected. It may be a clean surgery like simple lipoma or ganglion excision when you are just incising uninfected skin without opening a viscous. The chance of getting infected are less. When it is clean and contaminated, like you are opening a viscous deliberately, like in cholecystectomy, the chance of getting infection is more. When a clean surgery has a major surgical breach, it also counts as a clean contaminated surgery. Then comes contaminated and dirty surgery when there is obvious spillage of the colonic content or there is obvious uh, uh, pus, feces, or exogenous contamination tissue, like in surgical and trauma patient. And the chance of infections are 20 to 25% in contaminated and dirty, 25 up to repeated up to the 40% of the patient. And that's why it creates the huge burden. And this data from CDC in 2018 shows that for the patient, it extend the hospitalization, and for the system, it increase the healthcare cost. And that's why WHO has proposed certain range of precaution before, during, and after surgery to reduce the surgical site getting infected. So we'll dig little deep into it. We ensure patients bath before surgery to remove any particulate matter, any contaminant matter, because most of the surgical infection are endogenous flora. So it removes the particulate matter on which these bugs are adhered to. Regarding shaving, WHO recommended avoid shaving, avoid razors for the skin preparation because it create microabrasion. But if the surgeon is very peculiar about hairs not getting in the OT field, then hair removal should be done in OT with the use of hair clippers. We'll see the antibiotics in the next slides. Chlorhexidine surgical scrub and OT etiquettes are, as the surgeon is the population audience is surgeons, they know the best. And after surgery, you should continue check wounds for the infection, use standard dressing protocol on the primary wound. These are the same things I stated in previous slide. There are preoperative precaution, there are perioperative precaution, and the prophylactic antibiotic therapy to prevent surgical site infection. Now, these 3 points I would like to stress on perioperative management, in which the anesthetic team helps surgeons to get their patient better. It is avoidance of hypoxia and avoidance of hyperglycemia, because obvious reason there are more chance if the patient is hypoxic. Now, your OT is clean in the cold environment, but your patient fight better when he is warm. Because of hypothermia, patient develops coagulopathy, patient develops vasoconstriction, and patient's leukocyte functions gets deteriorated. So it is okay to invest in bear huggers, in body warmers in perioperative period for the patient while you are keeping your OT in a cold environment. Now, for antibiotic, The prophylaxis is indicated only for clean, contaminated, and dirty surgery. It is not indicated for the elective clean surgery. Now, your choice of antibiotic will depend according to the local practice pattern, local hospital antibiogram, and the timing of your antibiotic uh, will depend on the pharmacokinetic property of that antibiotic. You can repeat the antibiotic dose if your surgery gets prolonged more than 4 hours, and we do not routinely continue prophylactic antibiotic after 24 hours. And by any chance, if you are inclined to continue antibiotic, it's become an therapeutic antibiotic. So, despite all these precautions, certain uh, surgical patient catch infection, and the reason is multifactorial. So there are patient factor and some local factor like open surgery compared to lay, poor skin prep, contamination, inadequate antibiotic prophylaxis, prolonged surgery, tissue necrosis. But there are certain patient factor, we can work upon them, and we can reduce the SSI risk in those patients. So if any, suppose any obese patient, any coming from incisional elective incisional hernia surgery. So if that hernia was remaining for the years, they can wait for 2 or 3 months more, and they can reduce some weight. Old age, as usual, non-modifiable. Immunosuppressions, most of the patient who are post-transplant case, or they are a rheumatoid case, or some steroid or for bronchial asthma, we can check with their follow-up physician, and we can optimize the immunosuppressive doses. Now, for diabetic mellitus and malnutrition, obviously we can do optimization. We can ask the patient to stop smoking. We can optimize the renal failure drugs. We can correct the anemia. So there are some factors we can work upon and will reduce the risk factor. Obviously, there are expected bugs for the particular surgery. So, like if an orthopedic surgery is there, the most likely these are the skin common cells, Staph aureus, Coagulase negative, staphylococci. For appendixectomy, GNV comes in picture, anaerobes comes in picture. For colorectal surgery, gram negative bacilli and anaerobes. So always you can pause the video and see the table. And despite all precautions, there are some factors which leads to the development of surgical site infection. So if we dig deep into the microbiology, this is the usual distribution of the share of the etiological pathogens in a SSI. Now, there may be a geographic variation, and this distribution pattern can follow the normal variance. So, after surgery, in the post-op ward, you should continue your wound assessment to see that if this surgical wound is normally healing, or it is having some sign of inflammation, or are getting infected. This is the more complex sepsis wound score. It takes into the account of the wound characteristic and how much proportion of the wound is infected, or how much proportion of the wound is showing some pattern. So asepsis stands the mnemonics for additional treatment required for that wound, like addition of any antibiotics, additional drainage was done by the surgeon, debridement of wound required, any serous discharge, E stand for erythema, purulent exudate, separation of the deep tissue, isolation of bacteria from the skin swab, and due to improper wound healing, the patient's stay is prolonged more than 14 days. So you calculate the scores and you decide that patient's surgical wound is healing, or it is disturbed, it is minor wound healing, it is moderate wound infection, or it is severe wound infection. So any surgical wound getting infected will generate a host response, and usually it will be an immune response to fight with that pathogen. Now, if that immune response gets dysregulated, the patient becomes septic. So the sepsis is nothing but the life-threatening organ dysfunction caused by dysregulated host response to an infection. When it is associated with circulatory or metabolic dysfunction, it is associated with high mortality. It comes in the septic shock category. So let's see the continuum of sepsis. I know that more of the definition are obsolete now, but the patient, your surgical patient, post of day or two, and he's having fever, tachycardia, tachypnea, his leukocyte counts are high, or more than 10% beds and peripheral blood film and WBC counts are low. So patient is you come to think about that patient is generating some systemic inflammatory response syndrome, and in presence of an infection, it becomes and sepsis. That was the old teaching. Now, the modern definition of the sepsis has incorporated, it is grossly an umbrella term, and it is more, we can say it is not precise, but it is more like philosophical term. Severe sepsis and septic shock, that severe sepsis terminology has been obsolete now because every sepsis is severe sepsis. Either you have septic shock or you have sepsis. Now, the septic shock is microcirculatory dysfunction associated with high risk of mortality. Or in objective parameters, we can say that patient with sepsis, with hypoperfusion, in the terms of higher lactate, his mean arterial pressure is not maintaining despite vasopressor support. He's having prolonged capillary refill time. You can say that it is septic shock. Now, in the term of sepsis, there is life-threatening organ dysfunction, and organ dysfunction we should have some objective parameters by which we can define organ dysfunction. So this is the sequential organ failure assessment score that is consist of depending on the lung, and there are lab or clinical parameters. For brain, it is GCS, it is a clinical parameter. For the cardiovascular system, it is mean arterial pressure. For liver, it is bilirubin, coagulation, platelet, lung, PF ratio. So any deviation of the SOFA point, any deterioration more than 2 SOFA point was telling you that organ is failing. Now, this was the Q SOFA score or quick SOFA score, came used in 2018. Though the latest guidelines have recommended against to use it alone for the screening because it has shown inferior to SIRS criteria and modified early warning score. New early warning score we have seen yesterday talk. So QSOFA was designed to identify the patients who are at high risk of developing sepsis. But though it is more sensitive, but it is less specific. That's why it has taken a step back. So upon identification of a septic patient, there are certain steps you need to follow in a timely manner to improve the patient outcome. Let me give you an example. If a patient of acute anterior wall MI comes to the ER, its mortality is only 10% in a modern scenario. For septic shock, the mortality is 30%. That's how grave this medical emergency is. But obviously, the heart attack is taken a priority because of the public perception. So to change that public perception that septic shock is a medical emergency, you need to measure lactate level. If the lactate level are high, you should begin 3-step antibiotics, fluid resuscitation, and vasopressor simultaneously. And before administration antibiotics, you should obtain blood culture before administering antibiotic. That was the bundle from 2018. Now, this bundle has been criticized because of the timing of that broad spectrum antibiotic. So, what was the issue that there are diagnostic uncertainties. So, you are, if you are, if you are thinking that this patient is in septic shock, he's very critically ill, you right away administer the antibiotics. But if there are alternate diagnosis is available, and that's why the timing of antibiotic has been dissected in the 1 hour or 3 hours, we will see later. So upon recognition, you should initiate the treatment early. The septic shock is an emergency. You should begin treatment and resuscitation immediately. And mind you, the all three steps, you can see that all three infusion pumps are running simultaneously, the fluid, antibiotic, and vasopressors. So, for sepsis-induced hypoperfusion and septic shock, give at least 30 ml per kg IV crystalloid. Begin immediately to be given in 3 hours and do various measures to guide resuscitation. And what are the various methods for assessing circulation is you can use improvement in the mental status, you can use capillary refill time, you can use stroke volume or pulse pressure variation if the arterial line is in place, and you can see that if there is high uh, variation in high stroke volume variation, they are more likely to increase their cardiac output after fluid administration. Now, the concern about antibiotic timing was that if by chance there is any alternate diagnosis, so they have sort of dissected it. If your patient is very sick, he is in shock, you should administer antimicrobial immediately upon the recognition of sepsis within 1 hour. Now, if my patient is relatively stable and I think maybe some alternate diagnosis there, if I think that the sepsis is definite or probable, I will start antibiotic immediately. But if by chance, if there in the history or clinical examination, or we can wait for like 2 3 hours to know the any infectious or non-infectious cause of acute illness, then we can wait up to 3 hours in the initiation of antibiotic. And still, and if the concern infectious disease concern persists, then we can continue the antibiotic. Now, the choice of antibiotic will remain on the PK/PD principle. So, what are the pharmacokinetics and what are the pharmacodynamics of that antibiotic that will be uh, uh, deciding factor for your antibiotic administration. So, if you are considering aminoglycoside and if you are giving 500 milligram too early, that is the common practice in the post-op surgical notes, it won't help. So, whenever you are infusing any antibiotic, it achieves certain peak concentration, and with the metabolism and volume of distribution and pharmacodynamics, it gets what's out from the system. Now, there are certain antibiotics which have an killing antibiotic killing property at the Cmax, like aminoglycoside. So, if your prescription is saying amikacin 500 BD, it won't help. 750 milligram OD is better than 500 BD. Similarly, in beta lactams like cephalosporin or penicillin or meropenem, the antibiotic killing property is time dependent. So the more infusion, more time, prolonged time of antibiotic is getting in the blood circulation, it will kill the bacteria more effectively. Most of the time, as we see that in surgical ICU, the meropenem was is being given in 30 minutes bolus dose in 100 ml saline. It's like sending your army for 1 hour and giving them rest for next 2 hours. So this is the practice that can be changed, particularly in case of any carbapenem administration. Now, vasoactive management, mind you that all three-step fluid, antibiotics, and vasopressors are uh, uh, coming in picture simultaneously. So use of norepinephrine as a first line of vasopressor. In patient with sepsis and septic shock on pressure, your target should be 65 of mean arterial pressure at least, and after initial stabilization it should be individualized. So if a patient with chronic hypertension, the target of map of 65 will not be sufficient. You need to put mean arterial pressure at which his normal physiology would have worked. Now, in consideration, this is the weak recommendation considering the invasive monitoring of the arterial blood pressure, initiating vasopressor peripherally if you cannot access the central asset that has been included in the guideline. If the MAP is adequate despite low to moderate norepinephrine, you should consider adding vasopressin. And if the diastolic cardiac dysfunction with persistent hypoperfusion despite adequate volume status and blood pressure, you should consider adding dobutamine or switching to epinephrine. The most important step is infection source control. So if you identify any source of infection, in this case, our surgical site infection, or any IV devices there, that is, are you thinking that this is the possible source of infection that should be removed? You should implement the source control intervention as soon as possible, and daily assessment of de-escalation of antimicrobial treatment should be done. Now, after the fluid initiation, after antibiotic and hemodynamic stability, you need to de-escalate on the fluid content. It has shown that whatever the resuscitation amount of fluid you have given, after the improvement of that patient, you need to de-escalate. So by the end of day 4 or day 5, you need to give a patient a diuretic shot to remove excess fluid from the circulation. Now, ventilatory part and the general ICU care that has been already, ventilatory part will be covered in our next class by Dr. Deven Juneja sir. And the basic program like basic steps like nutrition, potty, CLAPSI, and a web prevention bundle has been taken care in yesterday's session. So by this, I will end my slide. Thank you. Over to you, sir.
Very nice and elaborative presentation, Dr. Pramod. I must congratulate you for such a crispy presentation. And any questions in the chat box, Dr. Ravi?
No questions, sir. We can
No
proceed with
questions,
the
sir, so
next
far.
session.
Yeah, Dr. Srishti, you are also there?
Oh, yes, sir.
So, okay. So, any questions? I think it was a very nice and elaborative presentation. I must think one thing that the SIRS or systemic inflammatory response syndrome still holds true. I think so.
Yes.
Because in many patients, what we see in acute pancreatitis or in trauma, I think SIRS has got a definite role. I think something which we discarded in the new definitions, but I think it still holds true. Okay, so I think we should move on to our next presentation. That is by Dr. Deven Juneja. Very good evening, sir. Are you there?
Yeah, good evening.
Okay, so Dr. Deven is the director in the Institute of Critical Care Medicine, Max Super Specialty Hospital, Saket, New Delhi. And he is the editorial board member of 3 international journals and peer reviewer for more than 50 national and international journals. He has more than 50 publications in peer-reviewed journals and more than 40 chapters in the critical care and related textbooks. And he's the co-editor of a textbook on critical care toxicology. And he's the lead author of many ISCCM position papers and guidelines. And he has received the President's Citation Award from Indian Society of Critical Care Medicine 2020 and got the Chairman's Award for Society of Critical Care Medicine Delhi NCR 2017. GEM Award for Max Healthcare 2017, Best Paper Award for Indian Society of Critical Care Medicine at Criticare 2010. And he's the Fellow of the Society of Critical Care Medicine USA. And he's the Fellow of Indian Society of Critical Care Medicine. And he's the Fellow of the American College of Chest Physicians. And he's also the life member of Indian Society of Critical Care Medicine, Indian Society of Anesthesiology, European Society of Intensive Care Medicine, and Society for Critical Care Medicine, SCCM. And he's also the executive committee member of the National Indian Society of Critical Care Medicine and secretary of the Society of Critical Care Medicine, Delhi, Noida. So welcome, Dr. Juneja. And his presentation is on the basic management of mechanical ventilation and oxygen support.
Thank you, Dr. Nikhil.
Over to you.
Yeah. Thank you, Dr. Nikhil. I'll be just concentrating on the basics of mechanical ventilation. Many times we know that when the patient comes to us in our ICUs, they require some kind of ventilatory support. The reasons for that is there is a chain of respiratory failure. So when our respiration is started from the brain center and neuromuscular connections are there, followed by the thoracic billows and the airways and the alveoli. If there is failure in any of these connections, then the patient might go into respiratory failure. And at this point of time, he is going to require some kind of support. So the first support which we generally provide our patients is giving them oxygen. In many patients, this is the only support which is required, but many patients require further respiratory support in the form of mechanical ventilation. So indications, the absolute indication for that would be acute ventilatory failure or arrest. If the patient develops higher CO2 levels associated with respiratory acidosis, then the patient is going to require some kind of ventilatory support. Impending ventilatory failure occurs when a patient can maintain marginally normal blood gases, but only at the expense of increased work of breathing. Then comes severe hypoxemia. If the PO2 is less than 60 on more than 50% FiO2 given through oxygen mask or nasal prongs, or even sometimes we give higher concentrations of mask through non-rebreathing mask. So even if the patient is not supporting well, patient is desaturating on any of these oxygen therapies, then again you should think of putting the patient on mechanical ventilation. Sometimes we have to give prophylactic ventilatory support, and post-operatively, as you must have noticed many times, even after the surgery, we are unable to extubate the patient. So post-operatively, maybe because of oversedation or use of paralytics or for pain control or for immobilization, sometimes in the post-operative period also we have to give prolonged mechanical ventilation. Or if there is decreased systemic or myocardial oxygen consumption, or sometimes to protect the airways. So if the patient GCS is low, then you would like to maintain the airway by putting in a definitive airway and connecting the patient to mechanical ventilator. So these are the different indications for putting the patient on mechanical ventilation. So when you look at the types of mechanical ventilation, you can further classify that. It can be divided into non-invasive, which is BiPAP or bi-level support, or high-flow nasal cannula. This has really become popular, especially after the COVID pandemic, when most of the patient had type 1 respiratory failure, and now high-flow nasal cannulas are available easily all across India. And invasive. But when you look at the different indications of putting the patient on mechanical ventilatory support, be it invasive or non-invasive, they can be simply classified into 3 broad categories. So my only take-home point, my major take-home point rather would be from this presentation would be, whenever you are thinking about three indications, whenever you are thinking about mechanical ventilatory support, think about three indications. The first is ventilation. That means the patient is unable to wash out the CO2. As I've already shown, the PCO2 is more than 50, or the patient is requiring pH is less than 7.3. That would be one indication. The second would be hypoxemia, so to give oxygen. And the third is to reduce the work of breathing. So all the other clinical conditions which we have just discussed will broadly fall into any of these three categories. So if any of these three things are present, hypoxemia, hypercapnia, or increased work of breathing, the patient may benefit from use of mechanical ventilatory support, be it invasive or non-invasive. In most of the patients, especially if you have got a monitored bed available with you, the choice of putting the patient on mechanical ventilation, the first choice would be to put the patient on non-invasive mechanical ventilation. But again, as I was telling you, that HFNC has become really popular, and there are certain significant or direct indications for which it has been shown to be really, really useful. You can see the machine over here. I'm sure many of you must have seen a similar apparatus in your ICUs. And this is easy to apply, portable machine. The basic function of this machine is to give heated, humidified air at high flows. So you can give oxygen at up to the flow rate of 60 liters per minute. So that is quite a high flow. That's why it is called a high flow nasal cannula. And when you're giving oxygen at such high flow rate, it will give you a pressure head. So depending upon, roughly, it is very difficult to estimate how much pressure head you are maintaining when you are giving oxygen at high flows. But roughly for each 10 liters of oxygen flow per minute, it roughly corresponds to 1 centimeter of oxygen. So when you are giving flow rate of around 60, so that roughly correlates to around 6 centimeters of pressure support. So that it will help you in reducing the work of breathing. It will help you in hypoxemic respiratory failure, although it is not clearly indicated. But recently, in the last 2 to 3 years, many papers have come which does show that it might be helpful in patients with hypercapnic respiratory failure too. But other common indications of using HFNC is acute hypoxemic respiratory failure, post-operative patients, especially when the patient has undergone abdominal surgeries. You do not want to put the patient on BiPAP. This nasal cannula, which you can see over here, it is very easy to apply. Patient is more comfortable. Patient can easily take in food. Patient can talk. So the compliance with this machine is much better than our traditional BiPAP machines. So peri-intubation and post-extubation respiratory failure. So these are the common indications for which we are using HFNC, but indication is also coming up in patients with type 2 respiratory failure, COPD and asthma too. So this is the BiPAP machine. Again, I'm sure all of you must have seen a patient being put on a face mask or a nasal mask. And our traditional ventilators, many of the traditional ventilators have the capacity to give non-invasive ventilation too. But there are smaller, more portable machines also available, which can be applied even in the wards, or patient can take it home also. So again, the indications of putting the patient on BiPAP remain the same as in invasive mechanical ventilation. But obviously, there are certain contraindications in which you should not put the patient on BiPAP. That is cardiac or respiratory arrest, severe respiratory distress, unable to protect the airway or clear secretion, because as you can see, patient is breathing through a mask. If the patient is unable to cough out the secretion, the chances of aspirations are significantly higher. Impaired consciousness, non-cooperative patients, hemodynamic instability or arrhythmias, facial trauma, or upper airway obstruction. So in these patients, you would not like to put the patient on BiPAP or give a trial of BiPAP and directly proceed with putting the patient on invasive mechanical ventilation. So it is very, very important for us to understand when we have put the patient on invasive mechanical ventilation, how does the basic physiology of breathing. So here you can see these are the various phases of breath. here you need to have a trigger. So trigger means when the ventilator will initiate the breath, it is going to require some kind of trigger or some kind of indication that the breath should be initiated. And this is called cycling. From one phase of the respiration, that is the inspiratory phase, the ventilator will move on to the next phase of ventilation, that is called cycling. So from inspiration, it will move on to expiration. That is what we term as cycling. Then we need to have certain limits when to limit the inspiration. And the importance of these phases of breath is that you must understand that most of the oxygenation happens during the inspiratory phase. So it is during this phase that the oxygenation is happening, and most of the ventilation, that means removal of CO2, happens during the expiratory phase. So if the problem is associated with oxygenation, it is the inspiratory phase where you need to make the changes. And if the problem is with the CO2 removal, then the expiratory phase where you should concentrate. If you look at the inspiratory phase also, inspiratory phase will have a flow area of at a particular point of time, there will be an inspiratory flow. Then there will be a pause time. Then it is followed by the expiratory phase. So it is basically the inspiratory pause phase where the maximum oxygenation takes place, because at that point of time, the air has whatever tidal volume you have set on a ventilator has already gone in, and the alveoli are totally distended and are in close contact with the lung capillaries, and there is easy exchange of oxygen which is happening from the alveoli to the capillaries. This pause time can be set up in different ventilators, but generally it is kept at around 10% of the inspiratory time. So talking about the triggering, this is how we tell the ventilator to initiate the breath. It can be initiated by the patient. When it is initiated by the patient, so the patient has to generate some flows or some pressure by which the ventilator will know that the patient is trying to breathe, and it will help the patient in initiating the breath. Or it can be triggered by the ventilator. So when the patient is in a controlled mode of ventilation, we can simply put it that after every 2 seconds or after every 3 seconds, the ventilator is going to initiate a breath. So that is called ventilator associated initiated breath. So these breaths are generally time dependent at like I was telling, that every 2 to 3 seconds, the ventilator will automatically, irrespective of the patient making any effort, the ventilator is going to deliver a breath. So, and sometimes it is pressure or flow generated. That means the patient has to generate the set flow, or patient has to generate a set negative pressure to initiate the breath, and then rest of the work will be done by the ventilator. Now we do have some ventilators, advanced ventilators, which can even detect the electrical activity of the diaphragm and initiate the breath accordingly. So here you can see, now this is where the patient is trying to initiate a breath. So patient takes a deep breath, or patient generates some pressure, some negative pressure. When the ventilator realizes that, yes, patient is trying to generate a breath, the ventilator will deliver the breath over here. And here you can see this is the mechanical ventilator generated breath. So it does not have any negative pressure. So the machine is automatically delivering the breath. So earlier we used to have what we used to call the controlled mechanical ventilation. Now what we have is a assist control. So basically the difference is, in controlled mandatory ventilation, all the breaths were mandatory, or that is generated by the ventilator. So the ventilator did not allow the patient to generate any breaths. And earlier, the clinical practice was also like that we used to sedate or paralyze every patient going on invasive mechanical ventilator. Now we realize that it is less fruitful for us to paralyze all the patients, and we want the patient to be actively involved in the mechanical ventilatory process. And it reducing paralysis also helps in early weaning of the patients. So now we have shifted over from controlled mandatory ventilation to assist control, in which the patients are also allowed to breathe in between. So This is the assist control. Here you can see the ventilator, the patients are generating the breath. There is a negative pressure over here, and the patient is allowed to take a breath. In this ventilatory mode also, we can fix the tidal volume or pressure support or pressure control rather, which it can be assist control, can be pressure control, or can be volume control. The differences of those we'll be discussing in the next few slides. And the triggers can also be set, and the patient is allowed to breathe in between. If the patient is generating a breath, the mechanical ventilator helps the patient and helps in achieving the fixed tidal volume, or gives the pressure control which has been predetermined by the physician. But if the patient is unable to generate any breath, then the ventilator delivers the backup rate at the predefined time intervals. So as I was telling you, these assist control can be volume control or pressure control. So these are the difference. It is not fair to say that one mode is better than the other. Both the modes have got their own advantages and disadvantages. So whenever you are putting the patient on any of these two modes, you need to know the advantages and the relative disadvantages of each mode. Then your patient should be fine. So like volume control, the set parameter is the tidal volume, and airway pressure is variable. So, and this constant tidal volume is going to get delivered to patient with each respiratory breath, irrespective of the lung dynamics. So even if the lung becomes stiffer, then also the ventilator will keep on delivering the same tidal volume which you have set. But again, the problem with this is that if the ventilator is delivering the same tidal volume, your pressures are going to be very, very high. So if the lungs become stiff, like in ARDS, if lungs become stiffer, then for the same tidal volume, say you have set the tidal volume of 400, the peak pressures, the plateau pressures are going to be much higher. So the pressures are going to be variable with every breath, but ventilator will make sure that the set tidal volume is being delivered with each breath. And there can be some patient ventilator asynchrony, and there is no leak compensation in volume control. As compared to volume control, now in pressure control, it is the pressure control, the pressure you are setting, and tidal volume is variable. So suppose if you have set a pressure control of 20, but your target is tidal volume. So you must understand that you want to deliver a tidal volume of around 4 to 6 ml per kg in a patient with ARDS, or a higher tidal volume of around 6 to 8 ml per kg of predicted body weight in a patient and other patients like asthma and COPD patients. So if with each breath, the tidal volume is going to be different. So when you set the pressure control, you have to stay there and you have to observe how compliant the lung is and how much tidal volume the lung is generating with each breath. So like if we're talking about asthma and COPD, when the patient comes to you in the initial phases, the patient will have severe bronchospasm. So suppose if you have set up a pressure control of around 20, in the initial phases, it is going to deliver less tidal volume of around 400 to 450. But if once this bronchospasm, you are going to give them a lot of bronchodilators, steroids. So once this bronchospasm settles, on the same pressure control of 20, the patient is going to get a tidal volume of 600 or 650. So you have to determine that what is your goal. And if the patient's condition is changing, you need to change the pressure control accordingly. So you have to be really careful when which mode you are setting, and your patient might require frequent monitoring while you are putting up the patient on invasive mechanical ventilation. So the tidal volume is going to change with the lung dynamics, and flow will also vary according to the patient's demand, and it compensates for leaks. So SIMV is another mode of mechanical ventilator. Again, it was initially intermittent mandatory ventilation. Now it is synchronized mandatory breaths are given, and patient is allowed to breathe in between. Like this IMV mode, it was that the patient was delivering getting breaths at frequent intervals, And in SIMV, the ventilator is going to deliver the breaths at predefined intervals, and in between there will be a window when the patient will be allowed to breathe on his own. So here you can see these are the breaths which are generated by the ventilator, and in between there is a window. If the patient is conscious, then the patient can generate his or her own breaths, and the ventilator will allow the patient to take a breath on his own. And these patient generated breaths can be further supported by adding some pressure support to this, and that will also help in reducing the work of breathing, because sometimes what happens is during this window, patient, rather than taking one breath, can take multiple breaths, and there is a tendency for the patient to get tired out in spite of being on invasive mechanical ventilation. Another setting which we regularly do in our patient is putting the patient on PEEP. Earlier there was a concept of physiological PEEP. Basically, this is a continuous pressure, and we used to believe that that alveoli need to be open throughout. And physiologically, it is going to require around 4 to 5 centimeters of PEEP. But now it is no longer called a physiological PEEP, which we need to give. The basic function of the PEEP is to keep the alveoli open, because every time the alveoli closes and reopens, there is a chance of shear injury. And you want to reduce this shear injury by complete closing of alveoli every time. So you give some amount of PEEP, around 4 to 5, to each and every patient you put on invasive mechanical ventilator. Again, there was a concept of zero PEEP or ZEEP in managing patients with asthma and COPD. The concept was that these patients are already having obstructive airway disease, so their alveoli are already distended. So you do not need to give any PEEP to such patients, because such PEEP can be detrimental or add on to already distended alveoli and increase the risk of barotrauma. So the concept was to give low PEEP or zero PEEP to such patients because their alveoli are already open. So indications for PEEP is, what the PEEP does, it keeps the alveoli open, and it also helps in increasing the mean airway pressure. When you increase the mean airway pressure, that helps in oxygenation. So any condition in which oxygenation is an issue, or lungs are getting very stiff, or there is atelectasis or collapse of alveoli, you would want to increase the PEEP in such patients. So like indications are ARDS, stabilized chest wall, and physiological PEEP to keep the alveoli open throughout the respiratory phases. So these are certain indications. But you also need to be aware that there can be complications associated with high PEEP, especially the risk of pneumothorax, or the risk of hypotension, because the high pressure are being generated, and it can lead to hypotension. So these are few risk factors which you must keep in mind. And contraindications for PEEP is increased intracranial pressure, unilateral pneumonia, bronchopleural fistula, because if you give high PEEP to patients who already have a bronchopleural fistula, it will delay the healing of this bronchopleural fistula and can be detrimental to patient outcomes. Now, when you look at the ventilator, you see that there are 3 different panels. The first is the graphic panels, where whatever changes you make, you look at the graphs and you decide how the patient is doing on a mechanical ventilator. Then there are some fancy knobs or buttons and the ventilator. This is where you make all the settings. And the third section would be the setting of alarms. Again, it is a very, very important component of setting up the ventilator. It is not only the basic modes and FiO2 respiratory rate which we need to set. It is also important to set the alarms of the ventilator. Otherwise, the alarms will keep on going and the patient might not get ventilated properly. So when you look at these alarms, these are the basic alarms which you need to put. Expired minute ventilation, which is around 10 to 20% above and below the inspired minute ventilation. Low pressure alarms, high peak pressure alarm. Your target is to keep the peak pressure less than 35 and plateau pressure less than 30 centimeters of water. But in certain patients, like in asthma, COPD, morbid obesity, the pressures might be relatively higher. So you might accept a higher pressure in those patients. Then you need to set the alarm for FiO2 apnea time or backup ventilation, like I was telling you, the patient is going to deliver. If the patient does not take breath in a defined time period, the ventilator is going to deliver a breath. That is called the backup ventilation. So you need to set the alarms for that. So in different modes, like in volume control mode, you need to check the peak airway pressure, the plateau airway pressure, and low pressure alarms. And during pressure control ventilation, you need to check the expired tidal volume and expired minute volume. So these are specific things which you need to monitor apart from the normal vitals of the patient, saturation, GCS of the patient, and also you have to do the labs, the basic labs like the ABG. So you have to look at all those things. These things are all very, very important while the patient is on any kind of ventilatory support. Another concept which you need to understand is the peak airway and the plateau, peak airway pressure and the plateau pressures. So here, when you look at this ventilatory graphic, obviously the tip of this graph shows the peak airway pressure. As I was telling you, it should be less than 35. And this is the plateau pressure, which should be less than 30 centimeters of water. Normally, the difference between the peak and the plateau airway pressures is around 5 centimeters. So if there are, what do you mean by peak inspiratory pressure? So when you talk about the peak inspiratory pressure, it is the pressure which is required to overcome the resistance offered by the airways, the lungs, and the chest wall. When you talk about the plateau pressure, it is only the pressure which is required to overcome the resistance offered by the chest wall and the lungs. So any problem which is associated with chest wall or the lungs will increase both peak inspiratory pressure and plateau airway pressure. But if the problem is with the airways, like bronchospasm, secretions, or blood in the airways, or even when the patient is on ventilator, if there is kinking of the tubes, then only the peak pressure will increase, the plateau pressure won't increase. So in conditions of the lung like pneumothorax, massive pleural effusion, morbid obesity, because the compliance of the chest wall or the compliance of the lung is affected, in such conditions, both peak and plateau pressures will be on the higher side. So when only peak pressure increase, the gap between the peak and the peak plateau pressure is going to increase by more than 5. Again, whenever you put the patient on invasive mechanical ventilation, from the day one itself, you should start thinking that how you are going to wean off the particular patient. Weaning starts from the time you have intubated the patient. But again, there are certain criteria which should be fulfilled or which should be looked at before extubating the patient. Okay, so like the ventilatory workload, if the patient is breathing very rapidly, then you would not like to wean off the patient or extubate the patient. Looking at the oxygen status, cardiovascular function, patient is hemodynamically stable or not, patient is not very having a lot of tachycardia, physiological factors, patient is conscious, patient is able to cough out the secretions or not. But the primary thing is why the reason for which the patient was intubated, whether it has been controlled or corrected or not. Only then you should think about extubating the patient. So weaning criteria, the required PEEP should be around 6 or less than 6. There is a index that is rapid shallow breathing index, that is F by VT. The F is the respiratory rate, VT is the tidal volume in liters. This is a simple formula. You put the patient on pressure support and you see what is the respiratory shallow breathing index, rapid shallow breathing index. If it is less than 105, that means the patient is ready for weaning. And PF ratio should be more than 175, saturation more than 94%, oxygen requirement FiO2 should be around 42, less than 40 to 50%, and patient should be able to maintain the airway and have adequate cough reflex. Again, when you talk about weaning, there are certain modes which can help you in weaning. You have to give a spontaneous breathing trial. If the one trial should last from 30 minutes to 2 hours, not more than 2 hours is required. Ventilatory mode is the pressure support mode on which you can try, or sometimes you put the patient directly on the TPs. It is not required to put the patient on pressure support first, then TPs trial, and then extubate the patient. You can do either of these measures and you can put the patient on pressure support ventilation, and you can extubate the patient if the patient is maintaining well on a pressure support of around 6 to 12. Why we talk about some pressure support, why not TPs? Especially in patients with asthma and COPD, there is a lot of airway resistance. And when we are putting a tube, it adds to the airway resistance. And especially for a patient who already has got a lot of airway resistance, this is a significant addition. Try blowing through a tube and breathing through a tube. It will, you will understand that a lot of resistance is there, and you have to generate a significant pressure to overcome this resistance. So this pressure support helps in overcoming the resistance offered by the tube. And if this is generally around, depending upon the size of the tube, the larger the size of the tube, lesser is the resistance. So sometimes if you have put a smaller size tube or there are a lot of secretions, this resistance can be significant, and it will add to the inspiratory work of breathing. And so that's why to overcome this resistance, you are going to require some kind of pressure support, and that is where pressure support ventilation comes in. But if the patient is able to maintain well on a pressure support, even up to 12, you can think of extubating such a patient. Just a few words about specific patient population. Like the patient with ARDS on one spectrum, there are specific mechanical ventilatory settings which you need to do. Once you put the patient of ARDS on invasive mechanical ventilation, these patients, the problem is oxygenation. So to improve oxygenation, either we give them high FiO2 or we try to keep high mean airway pressures by giving them high PEEP. What do you mean by high PEEP? Generally, as I was telling you, we put a PEEP of around 4 to 6, but in these patients, you might require much higher PEEP, up to 20 you can give. But again, whenever you are giving high PEEP, you have to look at the peak and the plateau pressures, especially the plateau pressures. Your target should be less than 30 centimeters of water. And depending upon your plateau pressure, you have to adjust your PEEP. Low tidal volume, around 4 to 6 ml per kg of tidal volume. So these patients are going to require less tidal volume. And to when you are giving less tidal volume, obviously the minute ventilation is going to get affected. The minute ventilation is going to go low. So to compensate for low tidal volume, you can either increase your respiratory rate, because minute ventilation is a product of respiratory rate and tidal volume. So you can increase your respiratory rate. You can go up to 35. Or the other thing is that you accept higher CO2 levels. So that is what we call permissive hypercapnia. As long as the pH is above 7.2, you can accept a higher PCO2 levels, and that is what we call permissive hypercapnia. Keep a pH of above 7, a higher pH of 7.25 is also acceptable. Plateau pressure, as I was telling you, keep the plateau pressure of less than 30 centimeters. Asthma and COPD on the other end of the spectrum, these patients are going to require low respiratory rate. And ARDS, we are giving them high respiratory rate. In asthma and COPD, we are giving them low tidal volume. We are giving them low respiratory rate. Here, the problem is not oxygenation. Here, the problem is ventilation. That is the CO2 removal. So here, what we do is we keep the respiratory rate on the lower side. Keep the I/E ratio, that is inspiratory to expiratory ratio. Normally it is 1:2. You keep a higher expiratory time, because here the problem is with expiratory flow. So you keep a higher expiratory time so that the CO2 removal can happen rapidly, and keep the expiratory time on the higher side. Keep a I/E ratio of 1.3 or 1.35, and keep the respiratory on the lower side. So again, be very, very cautious. If you are keeping high tidal volumes in these patients, or you are keeping low expiratory time, breath stacking can happen, because expiration is not complete and the next breath starts, and that can lead to auto PEEP. And auto PEEP you can detect on mechanical ventilator by giving an expiratory hold, and you subtract the given PEEP by the PEEP observed on the ventilatory machine settings, and that is the auto PEEP. It can be detrimental. It can lead to sudden fall in blood pressure. Patient will start becoming restless, having tachypnea, tachycardia, and hypotension. If a COPD or asthma patient is developing this, disconnect the ventilator immediately, decompress the chest chest by gradually pushing the chest in. It can help in immediate restoration of your blood pressure. And you need to take care of bronchospasm. You need to change your ventilatory settings, go to lower respiratory rate, lower tidal volumes, increase the expiratory time, and wash out the carbon dioxide or wash out the trapped air. So to summarize, invasive mechanical ventilation is, or any kind of ventilatory support, is an important adjunct to managing patients with respiratory failure. The broad indications of putting the patient on ventilatory support are three: oxygenation, ventilation, and to reduce the work of breathing. Patient with specific disease may require specific ventilatory strategies. One size does not fit all. So like I have shown you, patients with ARDS have got their own specific needs. And on the other hand, patients with COPD asthma have got their own specific needs. So you have to tailor-made ventilatory strategies as per the patient's requirement. Close monitoring and early weaning may help in reducing complications. Think of weaning of the patient from the time you have intubated the patient. Get them off early, because ventilatory support is also associated with certain complications. And always remember that it is not therapeutic. Ventilator support is not therapeutic. It is just giving you time so that you can take care of the underlying disease. So try to find out what was the underlying reason why this patient required invasive mechanical ventilator, and try to control the cause and get the patient off mechanical ventilator as early as possible. So as on a daily basis, give a sedation break. Think when you look at the patient, just look at the patient and see whether the patient is ready for weaning or not. I'll be happy to take any questions which you might have.
Thank you, Dr. Juneja, for a very simple yet very detailed description of mechanical ventilation. I think kudos to you for your presentation.
Thank you.
I think the major issue in a surgical patient is basically, especially in the cases of abdominal surgeries, is the basal atelectasis, and that leads to the leading to hypoxia, and they need a very good analgesia also. So I think that is very important points to when you are dealing with a surgical patient. Over to you, Anand, for any questions or.
Sure, sir. A few questions I had in my mind.
Yeah.
So most of this question is for Deven, sir. Most of the time we receive patients in our ICU, post-surgical patients, maybe major GI surgery, maybe simple GI surgeries, whatever has been prolonged. They lend to us with mild to moderate hypoxia. What do you think, sir? What could be the cause for this thing? Is ventilator-associated pneumonia or anything else like atelectasis could be present in these patients, and what?
Yeah, Dr. Anand, it is a very relevant question. By definition, the patient has to be on ventilator for a prolonged period to develop VAP. Okay, so if the patient is coming directly from the OT, the chances of it developing VAP is very, very less. So it is not that it is VAP. Maybe patient might have aspirated during anesthesia or might have aspirated earlier on only. And sometimes, because as I had shown you, because of the drugs, or sometimes because of the sedatives and the paralytic agents which have been given during the time of surgery, especially during abdominal surgery, many times you insufflate the stomach with gases. So that can also add to atelectasis. So all those things can happen, and which can help in perioperative time. Many patients are going to require ventilatory support. So for such patients, we earlier used to use BiPAP, because obviously it was non-invasive. You do not want to keep the patient, you do not want to re-intubate the patient. You have just extubated the patient. But now with the BiPAP, the problem is like after GI surgery, so your sutures can get disturbed or disrupted. And there can be a lot of gas insufflation, because you are putting a mask which the air is high flow. It is going through the mouth, it is going through the nose. So a lot of aerophagia is also there. So you are a bit skeptical. So now obviously we have started using HFNC. It is now easily available with us. So put the patient on HFNC. It will give you a pressure head. It will reduce the work of breathing. If there is some atelectasis, it will help in opening up those alveoli by giving a pressure head. And because of the high flow of the oxygen, it is going to resolve your hypoxemia also. Many patients are going to require in the perioperative period, especially in the first 4 to 6 hours, they are going to require some kind of ventilatory support. So it is very, very normal. So the reasons are many, as I've already enumerated.
Sir, another question from a colleague is ZEEP is still in use in obstructive airway disease. Should we use it or not?
That's why. So minimum, like I was telling you earlier, this was a very fancy term to ask in our MCQs also, that in which patients you can apply ZEEP. So obviously it is a fancy term, and we tend to use such fancy terms. But again, minimum PEEP which is required, you should give that. Normally in our day-to-day clinical practice, we do give a PEEP of around 4 to 5, even in patients of asthma and COPD also. But whatever minimum PEEP is required, you should give that for each and every patient. It is not true only for asthma or COPD. Even in ARDS patient, we try to come down on PEEP as soon as possible. And whatever the patient is tolerating, we try to come down on PEEP as much as possible. So zero PEEP, we generally do not apply. But yes, whatever minimum PEEP, around 4 to 6, that is the general practice.
Thank you, sir. So, sir, as you said, that atelectasis can be a problem in the post-operative period for hypoxia. I think the physiotherapy and good rehabilitation could be of good use in managing those conditions. So with this, I would like to invite our next speaker for this evening, Dr. Srishti Jain. She is an associate professor and additional director, ECMO at Mahatma Gandhi Hospital, Jaipur. She has got a vast experience of ECMO during first code of ECMO at Heart and Lung Transplant Center at Manchester. She is an equity research analyst and an ISM 15 certified personnel, and has got many original research and book chapters to her credit. She is a great teacher for the ICCM candidates and teacher for DM critical care as well. The core areas of interest is to finding ikigai in empowering humans to understand communication skills, to understand end-of-life care and palliative care. She is having an immense experience of self-finance management. I would hand over the mic to Dr. Srishti Jain for the next session.
Thank you so much, Dr. Anand. I'll just share my screen. Yeah, and let me put it on the slideshow. Right. Is the screen visible?
Yes, it is.
All right. Okay. So good evening, everyone. And thank you, Dr. Anand, for your warm introduction. And this is like one of my favorite topics, ERAS protocol. And I'll try to do a little justice to it in the 15 minutes being provided to me. And I am not here to teach ERAS. I am here to sensitize our young doctors, our young surgeons about ERAS, that why ERAS is so important. And I would like to start my presentation by sharing like what is ERAS protocol. So enhanced recovery after surgery protocols, they are multimodal perioperative care pathways which are designed to achieve early recovery after surgical procedures by maintaining pre-operative organ function and reducing the profound stress response following the surgery. The ERAS is a model of care introduced in 1997 by a group of general surgeons from Northern Europe, which were led by Dr. Hendrik Kellett. And these protocols include evidence-based techniques to minimize surgical trauma and post-operative pain. They reduce the complications, improve the outcomes, and decrease the hospital length of stay while expediting recovery following the elective procedures. So this is the chart of ERAS protocol, which we have made recently for our surgical ICU at Mahatma Gandhi Hospital. And this is like one pictorial view of what are the components of ERAS. So talking about the pre-operative components, we'll be dealing with the components later on, but just to introduce, the pre-operative components of ERAS are pre-operative counseling, pre-operative assessment about nutrition, patient's exercise status. The patients are told to have no solid foods after midnight, but they can have some light food till even 6 to 8 hours of surgery. There should be a short pre-op fasting time till 2 hours of surgery. They are allowed to have oral carbohydrate drinks. Initial prophylaxis of nausea and vomiting, like pre-operatively only a scopolamine patch could be, stuck to the patient. Carbohydrate loading till 2 hours before the surgery. Patients are taught exercises before the surgery. They are doing the spirometry, the lung function exercises already. And the intra-op components are regional anesthesia preferred over IV opioid analgesia. So in the form of rectus sheath block or subcostal tab block, right? Or classical tab block or bilateral 4-point tab block, depending upon the incision. No baths to avoid SSI, that is maintaining a normothermia, that is avoiding hypothermia actually. So putting warmers to the patients if they are really cold or coming from the theater. Oxygenation, try to keep FiO2 of more than 0.8 for 1 hour. Antibiotic prophylaxis, Dr. Pramod has already discussed very nicely in detail about the antibiotic prophylaxis. Underventilating, keeping an EtSCO2 of more than 38, glycemic control, skin preparation of chlorhexidine and more shaving. Then short-acting sedatives, right? Avoiding benzodiazepines, minimally invasive surgery, like laparoscopic surgeries are preferred over open surgeries. Intrafluid management, so it is goal-directed fluid therapy. We avoid normal saline, as we always say that there is little normal about the normal saline. So trying to use balanced salt solutions and goal-directed fluid therapy, basically like looking at the electrolytes and looking at the hemodynamics, urine output, and not giving a fixed formula of IV fluids. Avoiding hypothermia, again during the intra-op period. Early ambulation, early removal of Foley's, early removal of drains, post-operative maximodal analgesia, non-opioid analgesia, giving DVT prophylaxis, early oral nutrition. So these are all the components of ERAS protocol. And in the next few minutes, we will try to realize that why ERAS protocol is so much important for the surgeons. So we will be discussing about the guidelines for perioperative care in elective colorectal surgery, which were published in 2018. And Ulf Gustafsson, he's a Swedish surgeon, and he has given a very insightful talk on ERAS protocol, which is there available on YouTube. And I've jotted down the link to the YouTube presentation of his. And I think this is the most insightful presentation of ERAS I've ever heard. I remember me preparing my presentation for ERAS a few months back, and Dr. Ravi suggested me to hear this presentation on YouTube by Dr. Ulf Gustafsson. And the most beautiful part of this presentation is like he himself is a surgeon and how he takes us through. So I take permission to talk through his slides for my presentation today. So who are the top surgeons? And this is very interesting that whenever when a study was conducted and the surgeons were asked that, do you think you are a top surgeon? So 95% of the surgeons think that they are amongst the best 5%. Now, initially we might laugh over it, but then if we actually go into the depth of it, imagine me being a surgeon and me feeling that I'm not in the top 95, I'm not in the top 5%. How would I gain confidence to perform a surgery the other day? So that is why maybe it's kind of a self-fulfilling prophecy or kind of a mantra where you have to tell yourself, okay, I'm in the best 5% of the surgeons and I have to really perform very well, I have to save lives of the patients. So the top surgeon has to feel that way. So let us understand how you call a surgeon a top surgeon. What matters most? Either the surgical skills or the clinical judgment. By clinical judgment, we are talking about use of evidence-based medicine, interest in perioperative medicine. And the truth is that no surgical skill in the world can make up for the lack of clinical judgment. So this is how the surgeons think. 95% of they think that they are among the top 5%. So technical skills. So comparing the top 25% of the surgeons to the bottom 25% of the surgeon, this was a study published in NEJM in 2013. So the results were the least skilled surgeons had nearly triple the rate of complications. 14.5% versus 5.2%. And the least skilled surgeons required longer operative period, right? So this is what they found. But for 75% of the surgeons, the difference in surgical skills mattered very little, minor importance for the post-operative outcome. Then is it okay if 25% of the surgeons consider themselves as belonging to the top 5%? The answer is no. Clinical judgment. So interest in perioperative care, use of evidence-based medicine, that is what makes you a good surgeon. So if you are amongst the top 75% of the surgeons, the difference to the outcome of your patients would not be made by your technical skills. It would be made by your practices, following the clinical judgment, following the ERAS protocol, and your evidence, interest in evidence-based medicine, and following the perioperative care. So what is ERAS for the surgeons? Now, on the x-axis and the y-axis here. So on the y-axis, we are having the outcome. On the x-axis, we are having the skills that are required. And this is what truly ERAS is about. Your technical skills are just tip of the iceberg. And what really would make the difference, the 90% of the chunk which will have an impact on the outcome would be the ERAS items, what we just read about in the first slide. So it is your ERAS items that would be the predictors of the success, right? So this is something which we really have to remember. Now let's go back some years back, 30 years back, when there was no ERAS. It was a fast track era. Most of the studies on ERAS were done in the field of colorectal surgeries, and at that time, there were no surgeries. So colorectal surgeries are the major surgeries, and risk of complications are more. And if we were following the traditional care, because there was no perioperative protocol, open surgeries were done, there was slow recovery, high morbidity, long length of stay, no documentations were there, and even if the documentations were there, there would be a huge amount of bias because they would be done by the surgeons themselves. The morbidity would be anywhere between 10 to 75%. And doctors are the ones which are recording the complications. So obviously the outcome cannot be measured, and the surgical stress would be more. And this led to a very long length of stay. So Dr. Ulf shares in his video that he was working in a Swedish hospital in 1998, where there was a non-ERAS or a fast track era. And the surgeons were skilled, but there were no perioperative protocol. They were skilled surgeons, but not following the protocol. So they had no clue about the morbidity. And the length of the stay for a colon surgery was anywhere between 14 days. He also happened to work in a hospital in Uganda in 2001 in the non-ERAS era. And what he found, that the surgeons were obviously very skilled. They had immense caseload, and they were operating far more patients in one day that were being operated in any good hospital of Europe. But what would happen, despite the patient load, the perioperative protocols were ignored, and malnutrition was rampant, fluid overload was overlooked, and there was no clue about the morbidity, and they had very lengthy hospital stay. Even up to 30 days, there was a length of hospital stay. And then the first data on ERAS came from Denmark in 2000, and the surgeons were skilled, perioperative protocols were followed, and the morbidity was recorded, and the length of the stay came down to as less as 2 days. And this was one landmark paper which was published by the founder of ERAS, Dr. Kellett, and they found that if you were following the ERAS protocol, in the traditional surgeries, the length of the stay would be like around 10 days. But in fast track surgeries, the length of the stay had come down to as good as 2 days, which was really impactful. And in the recent ERAS data, the ERAS guidelines, what they found, that 30-day mortality, ERAS was safe, mortality was reduced, morbidity was reduced, risk reduction was reduced by 47 to 48%, shorter length of stay was noticed, and readmissions were less in the patients who were treated following the ERAS protocols. So ERAS protocol, why is it very, very important? See, we need to understand that surgery is a stress. Surgery brings in stress in the forms of cytokines, adrenaline, noradrenaline, cortisol is released. There's lipolysis, glucose uptake is reduced, there's insulin resistance, there's glycogenolysis, glyconeogenesis. All this leads to hyperglycemia, oxidative stress, and which in turn lands up the patient into a vicious cycle where there is more release of cytokines. And ERAS items, if we follow, all the ERAS items, we cannot exclude anyone. We have to follow them as a bundle, maintain compliance, do audits in our institutes that whether are we able to follow the ERAS protocols or not. And we find that, it reduces the surgical stress, it reduces the cytokines, adrenaline, noradrenaline, and the cortisol, and hence results in early recovery of our patients. So in the ERAS protocol effect, we find that the functional capacity of the patient, it comes back very soon as compared to the conventional treatment. If we follow the ERAS components like multimodal interventions for pain relief, exercise, feeding, stress reduction, so the functional capacity and the recovery is very, very, very much better. So ERAS items and evidence level. So is there an automatic correlation between a high level of evidence item and a high impact when used within the full ERAS program? So one way to find that is compliance, right? There are still not a lot of much of data about the compliance on the ERAS, and that is why we as the young budding anesthetist, surgeons, and intensivists, it is very important for all of us to conduct studies and to understand and see in our own units that how much are we compliant with the ERAS components, right? And then we will understand that how it improves the outcome. So this is one of the studies which tested about the compliance, and the overall compliance which they found in their study was around 71%. And what they noticed were that nearly all of the peri, and pre-operative ERAS items influence the different outcomes in a beneficial way. Independent predictors of outcome were goal-directed fluid therapy and carbohydrate fluid, before 2 hours before the surgery. Another study was done, and in this study, the independent predictors of outcome were doing a minimally invasive surgery like laparoscopic surgery, early oral food, and early mobilization, and the overall compliance was found to be around 60%. So to conclude, we say, Dr. Ulf has said in his YouTube video on the ERAS platform that ERAS for a surgeon, to summarize, that make sure that you are at least belonging to the top 75% of the surgeons. Make sure that you practice evidence-based medicine and enhanced recovery surgery. Currently, you have to use all items in the ERAS protocol. This is what the research has shown us so far. And we should regularly conduct audits and check for the compliance of the ERAS in the institute. So this is to summarize about what he had to feel about ERAS. And I would still say that it is one of the best talks that I've ever heard on ERAS. And another recent talk which I heard on ERAS was by Dr. Paul Wischmeyer, and he is the author of American Society for Enhanced Recovery and Perioperative Quality Initiative Joint Consensus Statement on Nutrition, Screening, and Therapy within a Surgical Enhanced Recovery Pathway. And he is a surgeon. He is also an anesthetist. And luckily, I happened to meet him very recently in one of the conferences. And I think I have heard such a beautiful talk after a very, very long time in my career. His talk made me cry. His talk made many of the doctors sitting there cry. So the talk was not just about him sharing experience of 2 of his patients, the stories related to the recovery after a surgery. His story also spoke about him. So malnutrition is an emergency in hospital and surgery. This is his talk, which I happened to hear that. And he says that malnutrition is an emergency in surgery. Mortality in GI oncology, if the well-nourished patients, is around 4%, but if they're malnourished, if they happen to have 20% weight loss, the mortality can be as high as 23%. And the reason why we cried during his talk, this is him. He himself was diagnosed as suffering from inflammatory bowel disease in his young college life. He's underwent 25 surgeries himself, He has hardly any bowel left. When he came to give the talk in that conference, he had the stoma bag, and he is still managing, still traveling everywhere around the world. He's still a tango dancer. He is an excellent bodybuilder. He's a personal trainer in the gym for many people. Such an inspiring story that was. And in this picture, this is him in July 2014 with his nice abs and muscles. And this is him in August in 2014 after his surgery. He lost around 12 kgs of weight and immense muscle mass in just 2 weeks of surgery. So this is what a surgery does to our patients. And that is why ERAS is so very important when it comes to the recovery of our patients, them going back to their life, then them going back and having a normal routine, they going back to their work, their jobs, becoming an independent member of the family again. So we have now enough data to suggest that ERAS is very, very important. ERAS saves life and it decreases the length of stay and lowers the complication rate. And very importantly, we need to understand and we have to give up our old traditional ways of practices, unlearn the old ways and learn the new ways. So ERAS protocol includes that no bowel preparation before the surgery, early NG tube removal, early enteral feeding, early ambulation, and no opioids. And this is again another infographic of a published study in JAMA in which they did a study on 80 elective colorectal surgeries, and they found that at 30 days after surgery, patients with the highest ERAS compliance had less moderate to severe complications. So again, coming back to the components of the ERAS, which we enlisted in the beginning, right? I just want to touch upon the few ERAS points which we fail to accept even after 13 years of evidence for ERAS, why we still are not able to adapt them and unlearn our old practices. So in the pre-operative component, we all understand that we don't need a longer fasting time. We can give carbohydrate rich fluids to the patient even until 2 hours before the surgery. This will decrease the insulin resistance. This will prevent hypo and hyperglycemias, and this will result in better infection control of the patient, right? Again, pain management is very important. We need we can give oral acetaminophen to the patient before the surgery, oral gabapentin in selected patients, oral cyclooxygenase COX-2 specific inhibitors. For selected patients, we have to give thromboembolic prophylaxis with subcutaneous heparin 5,000 units 30 to 60 minutes before the surgery. And in the intraoperative components, something which I really want to stress upon is use of minimally invasive surgical approach whenever it is feasible. Antibiotic prophylaxis first shot 30 to 60 minutes before the surgery. Use of short-acting anesthetic agents, inhalational, are preferred over the IV. Avoidance of fluid overloads, goal-directed fluid therapy, not just a fixed rate. Lung protective mechanical ventilation, maintaining normothermia, glycemic control, multimodal antiemetic prophylaxis like dexamethasone induction after the induction of anesthesia, ondansetron at the end of surgical procedure. For patients who are at very high risk of post-operative nausea, vomiting, we can give them a third antiemetic like scopolamine or intraoperative IV haloperidol. And we also have to think about avoiding the intra-abdominal or perineal drains. Yes, again, this is against our norm, which we have been doing. So we have now enough data to tell us that if it is an elective surgery, if there is no pus or an infected fluid, the patients don't need drain. It won't result in any betterment. So no drains, no gastric tube, right? Early removal of the Foley's catheter, all these should be considered. In the post-operative period, so enteral nutrition should begin on post-operative day 1. Yes, day 1. You don't need to wait for the return of bowel sounds. High caloric supplements twice daily. Multimodal analgesia, again, use of tab blocks or opioid sparing pain medications. multimodal antiemetic regimens, early removal of Foley's, and early mobilization programs, making them walk even on the evening of the procedure. So I would just like to stress upon early nutrition, that now we have enough data to suggest that early post-op nutrition is associated with significant reduction in total complications compared with the traditional post-operative feeding practices. So we have to give up the practices of NBM, CRTS. The patients don't need trials tube after elective surgeries always. They can be fed orally most of the time. See, we are not talking about the exceptions. We are talking about most of the elective surgeries of day in and day out. And it does not negatively affect the outcomes such as mortality or anastomotic dehiscence. Again, it is against the common belief that we will feed the patient can have anastomotic dehiscence. No, the thing is that if you start feeding the patients, your gut will be more healthy, the gastric juices would be used, because anyways we are producing 1.5 to 2 liters of juices just in our saliva and upper GI tract. So removing them and causing electrolyte disbalance doesn't make sense in today's era. Rather, feeding the patient would resume the bowel function and would rather decrease the length of the stay. So yes, let's be the doctors who follow the evidence-based medicine. Another important myth that why we don't start feeding our patients early is we wait for the return of the bowel sounds. The truth is that location of the bowel sounds. So bowel findings in one quadrant may not localize to that quadrant, as sound frequently travels along the entire abdominal wall, and length of your listen. So if you're not able to hear the bowel sounds, do you have the patience for waiting as long as 50 minutes? Because cycles of Borgere may last as long as 50 minutes. A healthy patient can have up to a 4 minute of absent bowel sounds. So are we ready to wait, auscultate in each quadrant, wait for 4 minutes each? So ideally it would require at least half an hour to 40 minutes if we really want to listen for the vowel sounds. Are we ready to wait for such long? So we have now enough data to tell us that vowel sounds are not associated with flatus or bowel movements or tolerance of oral intake after a major abdominal surgery. So again, coming back to the components of ERAS, that these are the component of ERAS. What will make you as a good surgeon if you are amongst the top 75% of the surgeons is your intention to follow evidence-based medicine. So and again, it is not an individual effort, it is a team effort. So when the patients, who are the stakeholders? Stakeholders are all of us, the surgeons, the anesthetists, the pain services, OR team, nursing team, nutrition team, pharmacy team. Everyone, all of us as a team are the stakeholders to make sure that ERAS is implemented in our hospital. So just to conclude, I would say that intelligence, what is intelligence? So intelligence is not because you think you know everything without questioning, but rather because you question everything you think you know. Thank you so much.
Thank you, Dr. Srishti, for such a nice talk on ERAS protocol covering IV fluids, antibiotics, and more or less everything a surgeon would be interested in knowing. So I had a question for you. Can ERAS protocol be followed in all surgeries?
So yes, that's a very good question, Dr. Anand. So again, nothing is in isolation. So if we have surgeries in which patients are hemodynamically unstable, if they are septic patients, if they are the surgeries which are done in emergency, then in those cases, implementing all the ERAS items would not be possible, and we have to follow as many as we can and maintain the compliance for as many as we can. What we can do as a team together is to have a ERAS checklist and to write down the reason every time we are not able to follow a certain item. So what will happen? We will be insightful. Okay, I'm not able to, for example, feed my patient immediately because the patient is on, let's say, a lot of dose of vasopressors. But at the same time, I am aware, my team is aware that as soon as the reasons for which I have not started the feed yet have gone, and I start the feeds, I slowly build up upon the feeds.
Thank you. Thank you for your answer. So now I would like to move on to our next topic for the evening, the management of blood transfusion. It's something which a surgeon is always interested to hear and understand. And today we have Dr. R.M. Jaiswal, sir, who is the professor and director of blood center and flow cytometry and transplant immunology lab at Mahatma Gandhi Hospital. He is a passionate learner, working for safe, advanced, integrated transfusion services. He's a hard worker, still sitting in his chamber, what I can get. And he has developed a state-of-art transplant immunology lab here at Mahatma Gandhi Hospital. He is a vice president to International Committee of the American Society of Histocompatibility and Immunology. He is active member of many societies and have been awarded by various agencies. He has lots of publications, almost like 32 in national and international journals. And when we talk of research specialization, the areas of his interest are apheresis, cellular therapy, transplant immunology, flow cytometry, and molecular, that is hemato-oncology cases. So I invite Dr. Jaiswal sir to take over from here and tell us when and how to transfuse blood and what could be where done best to these patients who are post-surgical, who needs blood transfusion, and when a surgeon can actually withdraw or can look for the cause not to transfuse. Over to you, sir.
Thank you. Thank you for nice introduction, Dr. Anand. First, I would like to give special thanks to Dr. V.K. Kapoor, sir, for organizing these kind of events, because these kind of events are very important for everyone, especially all the surgeons. Can I share my screen right now? Just you shift to my...
Sure, sir. You can.
I am not getting the this screen share option right now at present.
Okay.
Previously it was, but right now I'm not getting screen sharing option at this moment.
You are over, sir. You can see your screen.
This is my screen, but screen sharing option I'm not getting. Initially I was get, but at present I am not getting screen sharing options. 2 minutes back it was there when you are presenting.
Let me check, sir.
No, I'm not getting screen sharing option right now at this moment. I am sharing you a picture of this, what I am getting.
Click
Sir,
on
can
your
you share your PPT with me?
Yes, sure.
Sir, click on your main screen. You will see a share screen in the green.
Yes, Dr. Anand. Yes, right now is coming.
Okay.
Yes, now it is visible.
Yes, it is.
Okay, thank you, Dr. Anand, for nice introduction. And first, I would like to thank Dr. V.K. Kapoor, sir, Dr. Anand Nagar for initiating this kind of event, because blood product management and transfusion triggers, especially for the surgical patient, are a very important aspect. Today, agenda will be how we are dealing in the blood transfusion services, what are the blood management program and patient blood management. This is a newer concept at present, and what are the massive transfusion protocol and transfusion triggers and current recommendation. Recently, JAMA released recent recommendation for the RBC transfusion, and I'm going to discuss those important points. Blood transfusion services. First, we wanted to know the primary focus. First and most important is the improving blood safety, emphasis on voluntary blood donations, program blood donation screening technology, and safe and judicious use of blood components. And at present, most of the transfusion services are involved in the therapeutic procedures, just like a therapeutic plasma exchange and for sensitization of ABO in compatible renal transplant. So these are the important area of blood transfusion services at present. And when we are talking about the transfusion, so first we need to remember some bloody facts. The main concept of this: be aware and beware of all the transfusion. There's a very common dictum in transfusion medicine: best transfusion is a no transfusion. And transfusion, as we know, these blood products are the very one of the dealing with a very dangerous drug. So we should avoid. First, we should screen all our patient for the judicious use of blood and blood component. Then we can give the transfusion. And though it is commonly known as a blood transfusion, but literally blood, we are dealing with the blood as a tissue, and you can say we are dealing with the liquid transplant. Transfusion are double trouble for hospital-acquired infections. Blood shortage should be in the driver's seat of the decision making. And again, blood costs are the tip of the iceberg for the total cost of transfusions. And its implications for complications are clinical, economical, medico-legal, and ecological also. When we are talking about the transfusion,
Sir, sorry to interrupt, sir.
Yes,
Just make it in PPT mode, sir.
Okay.
Click on the right.
Now
Yeah.
is it clear?
Yes.
Okay. So when we are talking about the blood transfusion, to save blood, save lives, not only by the transfusion. Right now, there are a lot of concept is coming. Transfusion are one of the most overused treatment in a modern medicine at a cost of billions of dollars. And researchers are working on it. And recently, WHO also launches the program of patient blood management. And when we are talking about the process of the transfusion services, first, we need to generate the requisition, then donor screening and counseling. These are the internal process when you are sending the request for the issuance of blood. There are a lot of process behind the issuance of blood. We need to check a lot of things, especially as we know, blood transfusion is coming as a medico-legal aspect. So this is and it comes under the licensed product. So we need to be very careful and we need to be very cautious when we are ordering transfusion for blood component and any transfusion services. Safe Transfusion, WHO also launched one book on this. And the main objective of use of blood and blood products appropriately at all levels of the healthcare system in any country without compromising standards of quality and safety. The major focus areas are the appropriate use of blood and blood products, anemia, replacement fluid, clinical transfusion procedures, adverse effect of transfusion, and the most important is the clinical decision on transfusion. There are the two things. One is the liberal transfusion strategy and second is the restrictive transfusion strategy. We need to decide where we need to use a restrictive transfusion strategy and where we are going to use liberal transfusion strategies. And transfusion in a clinical practice, and it must be the disease specific and requirement specific, because most of the time we are aware of, especially in the dengue season, if a platelet count is coming down, so everyone is looking for the platelet, especially for RDP or SDP, even though patient is not required most of the time on the basis of the clinical history or clinical symptoms. And for this, WHO, especially in the 63rd World Health Assembly, especially in 2010, they adopted the resolution, and bearing in mind that patient blood management means that before surgery, every reasonable measure should be taken to optimize the patient's own blood volume, to minimize the patient blood loss, and to harness and optimize the patient-specific physiological tolerance. So this is a very important aspect. Before as we are aware, when patient is going for the surgery, we need to take care of all the investigations. And before relying on the transfusion, first we need to optimize the patient condition for the anemia, especially those patients who are especially coming, if they are anemic, first we need to correct the anemia, then we go for the surgery. It is not like that if in any case of elective surgery, we admitted our patient and then we transfuse and then we are going for the surgery. First, we need to identify the cause for the anemia. First, we need to correct the cause anemia. Then we need to take the patient for the surgery. And on this, there are a lot of societies working on this: Society for Advancement of Blood Management, Network for the Advancement of Transfusions Alternatives, and Australian Association, and International Foundation of Patient Blood Management. These are the major societies who is working for the conservative transfusion strategy. And the safe patient, when we are talking about the safe patient, that patient blood management rule automatically comes. The main important thing, the presentation and diagnosis, therapeutic decision making, and knowledge, evidence, and principle. What are the problem-based clinical practice guidelines, personalized and focus, patient-focused medicine. Then PBM, normally it based on the important three important pillar. One is the first, we need to identify. Second, we need to prevent. And third is we need to optimize. So these are the three important pillars of the patient blood management. And as we know, this is all about the patient centricity. We should be more focused on the patient blood, patient's own blood rather than allogenic blood. In view of that evidence case approach, it was published in the National England of Journal of Medicine in 2013, transfusion strategies for acute upper gastrointestinal bleeding, where they opted for the restrictive transfusion strategies when the hemoglobin level is 7 gram per dl, and it significantly improved outcome in patient with acute upper GI bleeding when compared with the lateral strategy. Transfusion, we are using these terms frequently in this presentation. The restrictive transfusion strategy, when we are going to transfuse when the patient is having hemoglobin of 7 gram per dl, and liberal transfusion when the patient is having hemoglobin of 9 gram per dl. And basically, we need to be the product-centric. And when we are comparing with the product-centric and patient-centric, initially it was used if a patient is having hemoglobin of less than 7, we need to be ordered 2 or 3 units of PRBC. But right now, single unit concept is in prevalent. We need to be transfused only 1 unit, then we need to assess, then we can go for the another unit as per the requirement of the patient. Again, in product centric, there are a lot of issue, fresh versus old. There's always debate and always debate on the fresh versus old PRBC, because stored RBC are having most of the time storage lesion. Those may not cause to expected increase in the hemoglobin, but there's a lot of debates on this, because blood comes under regulatory kind of things, and the shelf life of any PRBC, especially if I'm talking about at our center, because we are using leukodepleted PRBC, is a 42 days. And it depends on the nature of coagulant which we are using. It might be 35 days or it might be 42 days, but it is better to use newer PRBCs because they are having less storage lesion. And when we are comparing whole blood versus component, rational use of blood components, so these all factors we need to keep in mind. And when we are talking about the patient-centric, either we are going to deal with the surgical patient or non-surgical patient, because the requirement may be different in the surgical patient and non-surgical patient. There are various stakeholders in the PBM. When I am talking about the various stakeholders, the first and most important stakeholders are the clinicians, then clinical support team, hematologist, transplant surgeon, critical care specialist, oncologist. So most of the clinicians are the important part of this patient blood management, then clinical pharmacist, nutritionist, then patient representative, medical legal experts, public health experts, PBM implementation experts. These all are having very important role for the implementation of patient blood management. And this is a multidisciplinary and multi-professional unit. As I earlier mentioned, there are 3 important pillars of the patient blood management. The first and most important pillar is the detection and management of anemia and correction of mainly iron deficiency. The second important pillar is the minimization of blood loss and optimization of coagulation. And third and important pillar is the leveraging and optimizing the patient-specific physiological tolerance of anemia. And we need to be very judiciously use all the 3 pillars. And the concept of PBM first started from the Western Australia in 2008, where the government of Australia ordered every tertiary care hospital to follow strictly guidelines of the patient blood management. And this program was associated with significantly improved outcomes, cost saving of many millions of dollars, and significant reduction in the blood product uses. And nowadays, PBM is one of the very hot topic in the transfusion services, because it not only reduces the cost, but it also reduces the length of stay in the ICU setup, length of stay after surgery. There are a lot of beneficial effect of these program of patient blood management. As we know, the global prevalence of anemia, blood loss, and bleeding disorder, when I'm talking about the pillar 1, which is dealing especially with the iron deficiency anemia and identification, 2.9 plus billion individuals with anemia are present, and we can easily correct by giving some kind of iron therapy, or just iron therapy, or some kind of food supplementation. And when we are talking about pillar 2 and 3, 600 million individuals with chronic or acute blood loss and or bleeding disorders. And this may be because of major surgery, medical, and it may occur on medical and surgical ICU, GI bleeding, hemoglobinopathies. There are a lot of factors involved in this to correction of pillar 2 and pillar 3. That is the optimization and correction of bleeding, and identification of the bleeding, and cessation of the bleeding, or correction of coagulopathy. The concept of rational blood use started not early. It was earlier talked in way back, more than 60 years back in 1950, where it was mentioned that in a very important journal, that was the Blood, unnecessary transfusion poses a problem, and many of us deserve criticism for the way in which we have made this problem. And the reason for misuse of blood transfusion is that we are not sufficiently aware of what are valid indication for the procedure. Though this is a very true, most of the time, even the patient is having 10 gram hemoglobin, we are getting requests for the PRBC transfusion. But in our hospital, we are working as a team, and all the clinicians are very good. They understand this issue, and we are in the close conversation, and we are having very judicious use of blood. And we can say we are having very effective patient blood management program at our center. Then again, after 1958, the second article was published in 1963, where they stated, and this is the article from the JAMA, where they stated blood transfusion is short, and two aspects are at play: the false assumption, the modern laboratory methods are completely effective, and the popular belief that blood transfusions are tonic. I am stressing on these lines because these are the very important factor. We observe that even after many surgeries, clinicians are asked for the FFP, even in spite of the normal coagulation factor, normal PT-INR, but they are using these products just for the sake of, as mentioned in this journal, this is a very reputed journal, transfusions are a tonic with capabilities of correcting mild as well as serious disturbance in surgical and in certain medical conditions. Then again, paper published in 1978, blood transfusion use and abuse of blood components. This is a very important paper. On the basis of this paper, there are a lot of program was made by the US government, by the FDA, launched the program, and they decided, because this was the era when there was some transfusion associated infection was noted, especially for hepatitis C virus. And after that, they implemented some guidelines, and there was a mandatory testing after this paper. Now I'm talking about the transfusion practices during surgery. The use of blood and components in most elective surgery has decreased because of better patient management and use of meticulous surgical technique. The use of blood component in elective surgery varies greatly, and these variation depends on diagnosis, indications, difference in surgical technique. I have witnessed even in my hospital, initially we used to give 4 to 5 PRBC in the cardiac surgery, at least 10 to 15 PRBCs in the liver transplant surgeries, and 5 to 6 unit of PRBC in the renal transplant surgery. But at present, they are using very judiciously, and this demand is decreased up to sometimes there was no use of blood in the cardiac surgery and renal transplant surgery, and in Deven transplant surgery, which was initially 10 to 15 unit, reduced up to 2 to 3 unit as per the clinical requirement of the patient. These are the two scenarios, especially where the journey of an anemic elective surgery patient in ICU setup, and where patient is not having any not diagnosed for the anemia. And the second step after the implementation for the elective surgery, where patient is investigated properly and counseled by the family GP doctors, and whenever consultation is required, it was given for the optimization of RBC mass before the surgery. And after the optimization, then patient is booked for the surgery. In spite of, when I'm comparing with the scenario one, in spite of anemia, patient was booked for the surgery, and there was an unnecessary transfusion to correct the anemia for the surgery. Now it is changed up to the optimization of patient own blood by pharmacological agent, and after that the patient was booked for the surgery, and it gives drastic effect in the reduction of ICU stay, and it improves management of blood loss and of coagulopathy treatment of post-op anemia. Then I am comparing with the pillar one. So pillar one is the start optimization, and pillar two especially deal with the minimization of blood loss and optimization of coagulation. As in previous talk, Dr. Srishti mentioned that malnourished is the one of the important factor which can increase the mortality after post-operative surgery. So if I am comparing with the that thing, so minimization of blood loss and optimization of coagulation is improved if we optimize patient before booking for the surgery by detection and management of, especially for anemia. And the third pillar, that is the leveraging and optimizing the patient-specific physiological tolerance of anemia. We should not look for the specific lab requirement. If patient clinically requires transfusion along with the lab result, then we should ask for the transfusion request for the blood and blood products. Now, I am talking about red cell transfusion in critical care. Anemia after admission mainly caused due to the hemorrhage, hemodial, because critical care is the one of the unit where they are dealing not only surgical, they are dealing with the medical patient, they are dealing with the surgical patient, they are dealing with the post-operative transplant patient. So a lot of things in the critical care, they must be aware that anemia after admission is mainly caused due to the hemorrhage, hemodilution, frequent blood sampling. Again, just last week, one of the paper published in the JAMA for the frequent blood sampling that may lead to the heterogenic anemia. We should avoid by small blood volume sampling and inflammation. Most of the time, these transfusions are given to correct low hemoglobin rather than treat active bleeding. So we should focus on to prevent the bleeding, then correction of low hemoglobin. Then these again guidelines for the red cell transfusion in critical care, and this was published by the British Committee for Standards in Hematology, and they suggested that if the hemoglobin is more than 9, so first we need to take, if patient is hemodynamically stable, we don't need to give any kind of transfusion. And if patient is not hemodynamically stable and hemoglobin is less than 9, then again we need to think as per our other factors, patient either in the severe sepsis or in neurocritical care or with the ischemic heart disease. And on the basis of these formulation or guidelines, we need to decide our transfusion request. FFP transfusion mainly indicated for the treatment of bleeding in patient with deranged coagulation due to deficiency of multiple clotting factors, and the dose is minimally 12 to 15 ml per kg, equivalent to 4 units in average adult. It is not indicated for prophylaxis in non-bleeding. If patient is not bleeding and INR is within a normal range, you should not prefer to go for the FFP transfusion after each and every surgery. And we should avoid, because when we are dealing with the blood product, there's a lot of hazardous thing we are giving, especially we are doing 5 mandatory tests in our blood bank, but in spite of that, there are a lot of things we can giving hazardous things in the transfusion. So we can avoid all these things by the judicious use of blood. Then cryoprecipitate, again, if the fibrinogen level is less than 1.5, and if patient is in severe liver disease or bleeding, we can give fibrinogen, and especially we are targeting fibrinogen if less than 1.5 gram per liter. The most common blood product used to replace fibrinogen, but right now there's a lot of pharmaceutical products are available to correct fibrosinemia, and especially one product that is the PCC, prothrombin concentrate complex, we can use in the for the bigger surgery, or if patient is having a very deficient low level of level. Now I am talking few slides about the massive transfusion protocol, how to fix it. The option 1 is massive transfusion protocol, and now option 2 is massive transfusion avoiding protocols. And now we are using massive transfusion avoiding protocol, but because it ultimately leads to the switch for the massive transfusion protocol, it is also known as massive hemorrhage protocol, where we need to identify the culprit and we need to act on that in spite of giving a massive transfusion. To stop the bleed, save life dictum for MTP. And basically, if I am talking about the treat first, what kills first, and sequence is the very important factor. Massive transfusion protocol is basically established to provide rapid blood displacement in a setting of severe hemorrhage. And there are so many definitions of massive transfusion protocol. When we are giving 10 units of red cell in 24 hours, or total blood volume is replaced within 24 hours, or 3 units over 1 hour. So you can decide on the basis of various definitions, are you going to deal with the massive transfusion protocol? Because massive transfusion protocol can save a life, and it requires multidisciplinary approach, because there are a lot of things required to activate massive transfusion protocol, because as you know, FFP is always kept at -80°C, and for the thaw of FFP to 37°C, it requires near about 30 to 35 minutes. Then massive transfusion clinical settings, especially MTP protocol is mostly activated in cases of trauma, surgery, especially in liver surgeries, and less frequently activated for the abdominal aortic aneurysm, liver transplant, and obstetric catastrophe, and GI bleeding. And one of the massive transfusion protocol is also activated in the obstetric, especially in ectopic ruptured pregnancies. The other challenges, the type of component to be administered and selection of the appropriate amounts at that time. And time is a very critical factor when we are dealing with the MTP protocol. And in that case, in emergency blood use, we can immediately give O negative PRBC. And in minutes, if we have time, it is always a good practice. We should type ABO and blood group. Then we should give group specific blood, because O negative is not always readily available. And if you have time, then we have to go give these products after complete cross match. And if unit are issued without cross match, written consent of physician to be taken, and complete cross match protocols followed after issue. And as I already mentioned, when we are dealing with the emergency release of blood, just again, I am stressing on this point, when we are talking about the packed red blood cell, O negative is the universal donor. And when we are dealing with the plasma or platelet product, so AB is on the priority, then we can use A plasma or platelet. But for the emergency situation, O negative PRBC and AB positive or negative plasma or RDP product can be used for the emergency release. And the patient who sustained severe traumatic injuries and who are likely to require massive transfusion should receive 1 unit of PRBC, 1 unit of random donor platelet, and 1 unit of FFP in the ratio. And if required, we can give 1 cryo after correction of because it is a normal protocol of 1:1:1:1:1. But if the fibrinogen is more than 150, you can minus cryo, and after 1:1:1 in 10 packs, you can give at least 5 to 6 cryo in that ratio. And this is again the recent published data by the JAMA, where they suggested the ratio 1:1:1 ratio compared 1:1:1:2 ratio, where 2 is the RDP. And we are preferring 1:1. After 4, we can give 1 HDP. And we also used to damage control approach, where improved survival when the ratio of transfused FFP to platelet to red cells approaches 1:1:1. This was the published study, and they suggested if you use in this ratio, they will be the beneficial effect in the massive transfusion protocol. Just important at the onset, aggressive fluid replacement on bleeding control can reduce the tissue injury, inflammation, and hypoperfusion. Then untimely or complete control of massive bleeding, systemic congestive coagulopathy with hemodilution and endothelial damage. And if uncorrected, concurrent hypothermia and isostasis can further exacerbate coagulopathy and lead to multiple organ failure. Important is uncrossed match group O negative RBC or whole blood. Now there is a term low titer O whole blood can be used. Residual plasma with both antibodies can accumulate when large quantities are transferred. Repeat the blood group and do antibody titers before resuming transfusion of RBC of the patient's own blood group. These are the important factors we should keep in mind when we are dealing with the massive transfusion protocol. Again, these are the certain protocol template you can use at your own center. We are using at our center. We are making a template for the emergency MTP protocol. And basically, initial management of bleeding, first we need to identify the cause, and initial measures, compression, tourniquet, packaging. These are the important measures for the initial management of bleeding. And cell salvage is the another way where we can use cell salvage machine to use patient's own blood. And the doses we should always keep in mind. We should always keep platelet count. If we are using RDP, we should always consider the platelet count. If platelet count falls below the 50,000, if INR more than 1.5, and if fibrinogen down less than 1 gram per liter, or it is better to use tranexamic acid to correct all these things. The complications of massive transfusions are hypothermia, acid-base descent, coagulopathy, citrate toxicity. I'm not going into detail because the main important factor when we are dealing with these protocols, we should always keep in mind PT and APTT are the very important tests for the coagulation, along with the platelet count, fibrinogen, electrolytes. And now we are moving towards the era of viscoelastic tests, which can guide the appropriate amount of appropriate product for the use of the transfusion. And we should always keep in the mind if we need to keep target hemoglobin more than 10, hematocrit more than 32, platelet count more than 50, PT should be always less than 1.5, PTT is 1.5 of the control, and fibrinogen should be always at given point for more than 0.8. So now just this is the last 2 slides. First, we need to keep in our mind, first, do no harm. That is the primum non nocere. That is the one of the main objective of any transfusion protocol. Either we are dealing with the routine transfusion or dealing with the massive transfusion protocol. Patient blood management and patient safety is one of the important cornerstone when we are dealing with the transfusion. And by viscoelastic testing in combat resuscitation, is there time for new standard? It is always a good practice. If we are dealing with any kind of transfusion, first we need to go to assess what kind of product is required by the patient for the transfusion. And now 2 assays, TAG and ROTEMS, are very important, commonly used. We are using TAG at our center, and which provide the accurate information on the coagulation process through the graphic display of clot initiation, propagation, and lysis, and used to guide transfusion of blood components. So now I'm going on the summary and recommendations. And first, we need to define protocol triggers and algorithm for preparation and delivery of blood products, including continued support. And the protocol should be updated annually and practice skill drills to inform and train relevant personnel, because this is a continuous process. Initially, when there was the era They prefer for the whole blood. Now they came on the concept of component. Now there's a lot of paper is coming, which again favors the practice of whole blood. This is the latest guideline published only last week for the red blood cell transfusion by the JAMA and 20 in just the month of November. And this is the American Association of Blood Bank, which gives international recommendation, which suggests that we should always use for the restrictive kind of transfusion strategy, which stated if the hemoglobin is less than 7, then you can plan for transfusion. If hemoglobin is more than 7, you should always restrict your transfusion request. And keep calm and stop bleeding, because blood always gives some kind of anxiety, and especially during in the emergency or any rare traffic accident, there's a lot of confusion. Resident came by running, just give me blood, but we should be always keep calm. And first we need to be focused on the cause of the bleeding. And yes, we are having all the protocols to deal with the emergency situation, but please be calm and stop bleeding and avoid tocotalitrem and thrombosis by using judicious blood products. Thank you very much. Over to you, Dr. Anand. And I'm happy to take any questions if you have.
Thank you, sir. What a wonderful insight of the whole topic. It was really, what I can say, an excellent presentation here on this platform. And I hope not only my surgical colleagues, surgery residents, but in fact, the anesthesia and critical care medicine, emergency medicine colleagues would be able to understand when to give, what to give, and how much to give. Thank you, Jaiswal, sir. But before I conclude for this session, tutorial sessions, I would like to ask you a question. Sir, DIC, it's a common presentation.
Yes.
In post-surgical and maybe in perioperative periods.
Correct.
Does it needs correction of all the lab values, or we can stop at like not to give, when to give?
DIC is a very double sword condition. We always recommend we should avoid transfusion, because we are dealing with the consumptive coagulopathy. Whatever you are going to give, it is going to be consumed. Okay, if we are giving platelets, it is going to be consumed. If we are giving FFP product, it is going to be consumed, the products, the factors. So it is better, first we need to be, yes, if we are, again, this is a very tricky and very clinical condition. It depends on the clinical situation of the patient. So in that situation, first we need to identify the cause of, suppose I am taking the example of obstetric cases. So in obstetric cases, the retained placenta is one of the important factors to causing DIC. So first we should focus on the primary cause, and then we should go for the transfusion. And yes, again, we need to be very cautious.
Thank you, sir. So with this, I would like to conclude today's tutorial. And I would like to thank firstly Dr. V.K. Kapoor, sir, for giving us a platform like this, where not only surgeons, critical care medicine, anesthesiologists, and the hematologists can share the various insights of various topics which we commonly share. And I would also like to thank our faculties for today, Dr. Pramod, Sarva, Dr. Deven Juneja, Dr. Srishti Jain, and R.M. Jaiswal, sir, for taking out the time for this tutorial. And would like to extend my thanks to Dr. Nikhil Ajmera, sir, who had a busy day today, had to attend some family function, and he took out the time to chair a session. And anything else to add, Ravi?
That's it. Thank you, Anand. I think we should conclude the session over here. But as you see, the last slide, never stop learning, because life never stops teaching. So this session concludes with this note that whatever we have discussed in the last 2 days is just a tip of iceberg only. And you need to, like, we have books written on these five few topics. So you can dig in deep as much as you want. We tried to summarize as much as possible. Keep on learning, keep on achieving excellence. Thank you for us. I think we can stop here.
Thank you.